please, and as regard the fainting, is this the first attack?
Yes, doctor.
There is a complete loss of consciousness?
Yes, doctor. As I told you, they told me that my body is shaking.
Okay, what happened before this attack? You remember what happened?
No, doctor. I just felt that, no, I just felt that some lights in my eyes. Then I lost my consciousness.
What you are doing at that time?
Nothing, doctor.
Okay, and during this attack, is anyone notice what happened for you?
Yes, they told me I become bluish and my body started to shake.
Shaking all over the body. And after the attack, there is for about the attack lasted about 1 minute, and then regain your conscious level. But you are, according to your words, there is half an hour sleepy and like this. Okay.
Yes.
Yes. And there is no awareness of heart rate. Heart beat.
Awareness of what? Of heart rate?
Heart beat. Yes. Yes.
Yes, sometimes, doctor.
When?
I have it in different time of the day.
Okay. And according to your notes, also there is injuries to your tongue and other parts of the body. Where exactly?
It's and as I told you, in the tongue and in my head. When I fall down, I injured them.
Okay. There is any stitches or like this?
There's any what? Stitches?
Stitches. Yes.
No, doctor. They made some dressing and that's it.
Sorry for this question. There is any loss of control of urine or stool?
No, doctor.
Okay. May I ask you some question? Other question, please. Do you have any rash in your body?
Rash? Yes, doctor.
Yes.
I have some rash.
Where? I can see, please.
Yes, in my armpit and in my back.
Oh, sorry for that. And other sites other than this?
No, this is mainly what I have, doctor.
When this started?
Years ago.
Years ago. And no check for medical advice about this?
No, doctor. I have no time. I am a student in university, and I'm trying to utilize my time the perfect way.
Okay. Okay. And this rash, there is any color changes other than this color now? Is changing color before? When it started like this?
This is how it is, doctor, since 4 years or 5 years.
Okay. There is no pain or touch it?
2 minutes remaining, doctor.
Okay. There's any family history of this problem?
Yes. I have my brother. He has a problem. Also has a recurrent fits.
Okay. Sorry for that. And he received the medication and controlled, or
I'm not sure, doctor. He's not living with us.
Okay.
He's in a different country.
Okay. So there is any sweating in your body? You have a history of sweating?
Yes, doctor. I sometimes become very sweaty.
Sweaty. When this during this attacks or shaking
attack?
or shaking? Fits?
I don't know, doctor. While in fits, I don't know if I got it. I'm telling you in general, I'm getting sometimes this awareness of heartbeat, and I have this excessive sweating in my body.
Okay. There's anybody weight changes?
Which inches? I lost some weight, doctor.
Okay. What's your concern, Mr. Basim?
My concern, doctor, what's going on? Okay, why
Yes,
my blood pressure is high and why I got this fits?
Okay. This is mostly due to a condition called neurofibromatosis, and this disease affect this congenital disease. I mean, affect since birth, and this is disease affect your nerve fibers and can affect other part of your body, including skin, and look like disease rash, and also make some epilepsy or fits and high blood pressure also. Any other concern, Mr. Basim?
Time finished, doctor. Time finished. It is a score time. Give Dr. Fauzi his score, please, and then we'll start this. Scores. Okay, they give you between 26 and 20.
I think it's less than this. Actually, I forget. I don't have to ask some back history, family social history, and illicit drugs, and many questions. And no full examination also done.
Do you think the examination is? You didn't even offer to check the blood pressure.
Yes, and that's also like this. Yes, I know that's the problem.
Okay, so again, my comment is that you reach the diagnosis, and this is good. But again, doctor, I want a professionality. I mean, as I said, we are not beginner anymore. So now you need to know that, as I told you in the beginning of today, when you are going to the case, you will go. If you don't know what to check, what we said, Dr. Fauzi, what will be our action in this case? We're going to think about every part, right?
Yeah, sure.
So if I don't know exactly, if I can't remember exactly what to examine, I will start to go and tell him, show me your hands, extend your hands. If you see that his hand shakes, okay, then you check his pulse, okay? Then you are going to ask to check his blood pressure, right? So this is his arm, for example. Then you are going to check his chest for heart failure or the high blood pressure, for example. You need to check the rash. You need to check the abdomen for abdominal relief, right?
Sure.
So at least you need to show some stuff. If the patient has any weakness or something, you will start to do neurological examination, okay? Don't you think you need to ask some question about the cranial nerves in a patient with neurofibromatosis?
Sure, especially nerve 8.
Yes, so it's not only compressing 8, but you need to, that's why one candidate can take a full mark in this case, and the other one will take 18 or 16, although both of them reach the correct diagnosis. Sometimes it depends on the center, but if you're taking to examine UK, you need to know exactly what I'm going to examine because there will be fluent candidate there. They know exactly how to approach these cases, right?
Sure.
Okay, but anyway, you reach the good diagnosis. Okay, you went through the diagnosis with fits, you got the differential. Tell me what the differential you got outside.
Neurofibromatosis, adult polycystic kidney disease, drugs, the illicit drugs all over.
Very good.
Recreation drugs.
Yes, very good. Because yes, fits can come as a result of hemorrhage with polycystic ovary, polycystic kidney, and high blood pressure. I agree with that. And illicit drugs you can lose again can increase the blood pressure and you can get fits of that and neurofibromatosis. So if you put a reasonable differential outside, you can look for it. But if we found everything going negative, you will go through the algorithm, right?
Sure.
Okay. Then the structure. This case is short to be able to do to ask everything in this short time, but for the social, but at least some question would be helpful. Don't you think patient with fits? You need to mention something about driving. He is above 16, so he can drive. The people above 16 years old, they can drive. So don't you think driving is an important point in this case? So if you're asking me about smoking or driving, what do you think is more important in this case?
Driving.
So some advices about driving, about climbing, about swimming. Don't you think it's super important to mention something like that?
Sure.
Especially if he's not seen yet by the neurologist, for example.
Sure.
So these are the things that you may lose marks in. So practice and remind yourself. After this case, everyone, I want you to write that what's missed by Dr. Fauzi. So Dr. Fauzi, and you will not miss this part, and you will impress your examiner. So here, you will lose marks because you didn't examine the patient well, and you will lose marks because you didn't give the patient the precautions well, right? Although you reach the diagnosis, and this is what I'm all the time preparing you to do, but the part that you should do is practicing not to miss the simple things that may be related to the case, right? I like your differential. That's why I'm telling you your score in this case will be between 18 and 22, because you eventually reach the diagnosis. Okay.
Okay.
Thank you. Thank you, Dr. Fauzi. Thank you.
Okay.
Just give me a second. Doctor, I didn't ask you yet some questions, so tell me about.
So sure. Yes.
Tell me, what's the mode of inheritance of this, the neurofibromatosis?
Autosomal dominant.
Autosomal dominant. Okay. And what is the features you know about neurofibromatosis 1?
It is associated with rash, skin, cough, and also there is fits, maybe fits.
That's it. Okay.
Yes, I remember.
Okay. So you need to examine cranial nerves. What cranial nerve you?
Sure. Acoustic neuroma. Yes. Okay.
What else other than the cranial nerves you want to examine in this patient? Neurologically.
Cranial nerves.
Anything else? Okay. Why do you think these patients? Why do you think these patients have the hypertension? So what's the secondary cause of hypertension in neurofibromatosis? Answer in the chat box, doctor. I need everyone to answer this question, not for Dr. Fauzi only. Why the high blood pressure for patient with secondary causes of hypertension patient with neurofibromatosis? Yes. Fibrocytoma and renal artery stenosis and coarctation. Sometimes coarctation of the aorta. So three things. Fibrocytomas, renal artery stenosis, and coarctation. Okay, so Dr. Fauzi, what are hereditary conditions that may be associated with fibrocytomas?
You mean
other things?
Association with
Yeah, other things other than the neurofibromatosis. What else you know may have fibrocytoma?
I think acoustic neuroma.
There is one thing you should say. You should answer this question. Men, doctor, men. Multiple endocrine.
Yeah, sure.
Okay,
sure,
so it's
yes.
very important. Why? It is sure, but the examiner, if you didn't give him this answer, he will be very unhappy, right?
So this is in my writing.
Yeah, but you should answer this. So neurofibromatosis, Minn syndrome, and von Hippel-Lindau. For the von Hippel-Lindau, there is visual disturbance and headache, and there will be liver and kidney cysts and pancreatic and ear and epidermal epidermis adenomas. So this for von Hippel. It's coming also can come with fits, high blood pressure, or the same. Okay. So
okay.
These are the questions I want to ask you for that. Let me now show you this some details about the neurofibromatosis. Just give me a second.
So what is the management, Dr. Mohammed? Asked. So multiple surgery in the team. Hello.
Yes, doctor. I mean, in the management, you are not supposed to treat the patient with neurofibromatosis yourself. You will include for sure the skin doctor, you will include the nerve doctor. This is what you are going to tell the patient, or if you are telling the examiner, the neurologist, and the hematologist. Okay, and the patient, if he has concern about how it looks like, if the patient has neurofibromas or gets full fibromas, there is surgical excision, there is plastic surgery. The patient will be on antiepileptics, antihypertensives, and sometimes they need surgeries. Okay, this is enough in the answer. So let me now show you this part. Neurofibromatosis can come as a rash, hearing problem, balance problem, rash and uncontrolled hypertension, rash and fits, rash and sweating and headache. Any of these can come because of as a feature of neurofibromatosis. You will ask about the onset and course and duration, on and off. How does the rash start? May have a look. Then ask about the worsening factor and about biopsy, as all the questions we usually ask for the skin problems. Okay. Then you will ask about the eye. If you have any blurring of vision or see double, this is because of what's called the Lisch nodules and the cranial nerve compression by optic glioma. I want you to focus with me now in this case because this will make it easy. I know these type of cases are nightmares for some doctors. Some doctors, when they find neurofibromatosis, now if you are new to cases, when you hear someone have a neurofibromatosis case, you feel, oh my God, what should I do? What should I do with this case? What should I ask? What should I examine? But inshallah, after the lecture, you will feel very confident to have such case because as usual, what my plan, we give the algorithm to catch the diagnosis, and then you know what to ask and what to examine and how to answer the questions of the examiner. And this is all what you want to know for cases, okay? For the eyes, I will ask about I will take it from up down. Do you have any blurring of vision or see double vision? And this in my mind because Lisch nodule and cranial nerve compression by the optic glioma, okay? Then I will ask about the neurology. I will ask about the compression of the cranial nerves because of the acoustic neuroma compressing the cranial nerves. So I will ask about problem with showing foods, and you'll find on this page that this is for nerve 5. Do you see things double? This is for the abducent, the 6th cranial nerve. Does soup enters your eye? Does the soup enters your eye during washing your faces? For example, this is for cranial nerve 7 for facial problem, any mouth deviation, any feeling of imbalance and tinnitus and hearing problem, or the affecting neuroma affecting cranial nerve 8. Okay, do you cough normally? These are what I call the screening question of the main cranial nerves. So whenever you want to ask about the cranial nerves or any case, very fast, I want you to copy this part and keep in your mind. You can just ask this question about the problem in hearing or balance for cranial nerve 8. Do you cough normally for cranial nerve 9 and 10? Turn your head normally for 11. Okay, then other questions I would ask for the neurology affection, because neurofibromatosis can be associated with acoustic neuroma, with brain aneurysm, with spinal cord malformations. So many things can be neurological symptom of neurofibromatosis. You'll ask about headache. You'll ask about sweating or fibromatosis as a part of MEN2 as well. You have any neck swelling for MEN2, any weakness, clumsiness for spinal cord compression, any fits. So you don't need to ask all these questions actually, but as much as you can ask about headache, loss of consciousness, epileptic fits, ask some questions about cranial nerves, this will be enough. Then go to the cardiovascular and the lung, ask about shortness of breath, ask about the uncontrolled hypertension. And as you know, that the patient may have lung fibrosis and may have pneumothorax. Okay, so these patients may have cough, shortness of breath. For the cardiovascular, these patients, they may have heart failure because they may have restrictive cardiomyopathy. And remember at the same time that fibromatosis and renal artery stenosis. Okay, so this patient may have uncontrolled blood pressure. So that we need to ask about shortness of breath and uncontrolled hypertension. Musculoskeletal, these patients may have bone pain and they have a swelling. And remember that bowing of the long bone, presence of bony lesions, that's called as a sphenoid dysplasia or thinning of the long bone. This is part of neurofibromatosis type 1. So you may find this patient have a bone vein, have a deformity in the bone. Okay, then you need to ask about the family history. And why we said that? Because there is a criteria for the diagnosis of neurofibromatosis, mainly type 1. So again, I will ask about the rash. If it came by rash, I will ask about the hypertension. If it came by hypertension, I will follow the algorithm. There is no change in the weight. There is no weight gain. You will go to the right side of the algorithm of hypertension, and then you will reach the suprarenal causes, and you'll find the rash, and you'll find fibromatosis, for example, or you may find with the rash, fibromatosis and presence of fits or healing problem, and all this stuff you will exclude, or you will approve the neurofibromatosis. Then you will go ahead and confirm your diagnosis by asking the eye symptoms, the neurological symptoms, the chest and lung symptoms, and musculoskeletal and family history. Okay, when you go to examine this patient, you will look to the skin rash, and you need to remember the criteria of the skin rash of neurofibromatosis, which are there is 6 or more Caffioli spots, and the size of these Caffioli spots, this is what you see here in this case. You see this is Caffioli, okay? You see this one Caffioli macules, okay? The size of these macules and the numbers are important because in the criteria of diagnosis of neurofibromatosis type 1, although there is no time to ask you about these details, but you need to mention that if there is 6 or more Caffioli macules, it should be big enough. In adult, it should be above 15 millimeter. I mean, 1.5 centimeter in size, in diameter, and 5 millimeter in kids. You need to find 2 or more neurofibromas, okay? Or 1 lixiform neurofibroma. The lixiform is a big painful one. It's a very big painful neurofibroma, okay? You need to find axillary and groin freaking. The freaking is not normal to be found here in the axilla. Okay, so if you found axillary freaking or groin freaking, this is going with the part of neurofibromatosis. Okay, optic glioma in the eye. Okay, so this is a component of the diagnosis. Lesch nodule, what's called lesch nodule, is a part of iris. There is hamartomas in the iris. So in the eye, you may find optic glioma. You may find iris hamartoma or lesch nodule. Okay, so you need to offer to examine the eye movement and the visual acuity and the field because of many things, because of the affection of the eye itself and because of the compression of the cranial nerve. So you should, Dr. Fathi, you can't pass this case in the examination. You will not get a good marks if you didn't offer to examine the cranial nerves. You need to examine at least the eye movement and the visual acuity for the optic nerve, and for the eye, the optic glioma, you need to examine the eye movements as well.
In the start or at the end of the examination? But that's the question. When I can offer the cranial nerve examination?
Yeah, early, because this is the only thing that you want to do. It's more important than examining the other things. If you look to the examination, there is nothing to do. Let's say skin rash, you just take a look, right?
Then I have to look at the chest. I have to explore the chest, the abdomen.
What do you think more important in this case? More important to waste your time to examine the abdomen? I would agree with you for auscultation of the renal artery per week. Okay, but if you will go and examine, if you are asking me if I examine the chest and the abdomen first, no, I will start from up. I will offer that. I would like to examine the eye movement and the visual acuity. Maybe I'll tell you, guys, it's your time. So just do some examinations. Examine the hearing by only. I will show you in the neurology lecture. Okay, that how to do the cranial nerves in 2 minutes. Not all the cranial nerves, but the major cranial nerves. Let the patient blow, let the patient whistle, and this is enough for cranial nerve 7. Let the patient move his tongue. This is enough for number 12. Okay, you should show the examiner that you are doing the cranial nerves examination, not full, but at least show him that you know that cranial nerves could be affected. Okay.
Okay.
Then the CNS, you need to examine hearing, check hearing aids, look for facial sensation, facial nerve exam. This is what I mean. So the eye and the CNS both will be part of cranial nerve examination. You will offer to examine the chest. You will offer to examine the chest and the heart. Okay, and usually they will tell you no need if they know that the time will not allow you. Okay, then the abdomen for the renal, sometimes they allow you, sometimes not, and you need to look to the back for the scoliosis or the scoliosis. Okay, so if you look in this case, you'll find your main examination will be checking the rash and doing the cranial nerves. Do you think the time will not allow you to do if you started in the 3rd minute?
I think
you get the diagnosis very early. I mean, once this patient told you I have a rash, you will take a look for the rash. And with the history they gave you, don't you think it's very obvious diagnosis?
Yes.
It is.
Yeah. But the problem that when I read the scenario, the first thing from my mind is pheochromocytoma. So I have to exclude associated symptoms of pheochromocytoma, including MEN2 and.
Totally agree. What if you make it a little bit early and ask about the rash in the algorithm? Don't you see that there is a rash before fibromatosis?
Yes.
So if you just throw the question of the rash, this may solve the problem and make it more early. You are not supposed to still need to exclude all these once you see the rash and you see that we're talking about neurofibromatosis. Does that make sense?
Yes. Okay. But if the rash is only it's enough to exclude the MEN2.
Yeah. Don't confuse yourself. Yeah. If you see this specific rashes of neurofibromatosis with symptoms of fibromatosis, I would not recommend that you would waste your time to ask about other differential diagnosis of fibromatosis, right?
Yes.
In station 5, you don't have time to do all that. Do you think, Dr. Fathi, if you catch that this is the rashes of neurofibromatosis and the patient have the hypertension because fibromatosis associated with neurofibromatosis, this is not enough to get the full mark?
Yes.
Yeah, this is the point. Do you think they will cut some marks from your score because you didn't exclude MEN syndrome in a case that you just catch it in neurofibromatosis? No. So you are overestimating the cases if you think that. Okay. Okay, doctor. So this is how to ask, and this is how. Thank you, Dr. Fathi. You did very well. I appreciate your performance. Okay. This is the freckles that you can see, and the axillary freckles. This is the Caffioli. Okay. This is the neurofibromatosis with the plexiform. This is neurofibromas. Okay, and plexiform. The plexiform is the very big painful ones. If one only is diagnostic, one only of the plexiform is diagnostic. Okay. It's a horrible disease, by the way. So these are the criteria. You will receive these papers. These are the criteria for the diagnosis of type 1 Okay, there's 6 or more cafe 2 neurofibromas, axillary and bronchials, 2 or more nodules, bony lesions, first degree affected. Investigations for these cases you will do for the blood pressure. You will check the blood pressure, as Dr. Fateh said. We need to check the postural hypertension. We'll do imaging for the optic nerve gliomas, chest CT and X-ray for fibrosis, renal tract ultrasound for the renal artery stenosis. So a special test as slit lamps for the nodules. Okay, we need to do the urinary metanephrines to screen for fibromatocytoma. And for the management, non-pharmacological, including education, support, genetic counseling, and family screening. Medications for this patient, if it has refits, we need to give antiepileptics. For sure, we will include the other doctors. We'll not treat ourselves. The antiepileptics, very important, antihypertensives. Okay, then removal of the lesions. This is surgical if it's causing compression. Okay, and if the patient asks about the rash, you can offer him referral for cosmetic surgeries or the surgeon that can remove some of these ugly lesions if they don't like how does it look like. Okay. When we come here, this is because there is some confusion or some mixing between the tuberous sclerosis sometimes, because let's be realistic, we don't see these cases in our real life frequently. Okay, you may find this case of tuberous sclerosis, and the tuberous sclerosis can come with the first seizures and skin rash, hematuria, autism, learning disabilities. Okay, and if you wanted to remember, epiloia, this is not mine, it's common to be used with the tuberous sclerosis, the AP for epilepsy, the IL for low intelligence, and the A for the adenomyosis. Okay. These are they use it to remember the tuberous sclerosis. So this you'll find this in the nose. You'll find that you see that many times in your real life. Maybe you don't know the diagnosis when you see them in the street. This is what's called the adenomyosis. You see it looks like vesicles, like little small vesicles. It's around the nose and in the nasolabial fold as well. Okay. You may find this in the nails. Okay, you will find we will go through all the differential. This is what's called the endofibromas and the nail bed, which is very common. Here I will show you on this slide the percentage of the affection, because I don't want you to think that you will find everything in the case. You shouldn't find everything in the case of the tuberous sclerosis. Okay, for example, let's say what's happened in these patients, in the brain, 70 to 80% have subepidermal nodules. Okay, so this will cause the CNS symptoms if there is the tumors in the brain. The tumors of the brain can cause a lot of many things. Mainly, in 75% of cases, you may find seizures. That's why the association of seizures and the presentation as a seizure in tuberous sclerosis is very common, because 80% of these cases may have tumors in the brain. Okay, 50% of cases may come with mental retardation. There's 2 cases of tuberous sclerosis in Egypt. 2 cases. You will see it in the clinical courses if you attend there. So you need to ask this patient about any history of headache, any history of loss of consciousness, weakness, altered speech, uncontrolled, unsteady gait. So you need to ask about all the neurological symptoms of brain mass. Okay, blurring of vision, loss of vision. All this need to be asked. Okay, because it's very common to have tumors in the brain. Okay, the eye, the retinal hamartomas is not uncommon. Okay, so 50% is a good percentage. So this patient should be asking about any eye pain, about any visual disturbance as well. Okay, oral symptoms. These patients may have in their mouths. In their mouths, they may have gingival hamartomas. They may have beveled uvula. So you need to ask about any eating, teeth, mouth cavity abnormalities. Okay. The lung, 40% of patients may have problem in their lung cyst, and what is called lymphoangiomyomatosis. Very big names, by the way. But there could be short of breath, so you need to ask the patient about the neurological symptoms, ask him any blurring of vision. Again, you don't need all these details for places, you need to know what to ask, what to examine. So what to ask, any loss of consciousness, previous seizures, any blurring of vision, any difficulty in speaking, okay, any vision problem here, okay, any double vision, okay, any shortness of breath, can I see the lesions, can I see the skin rashes, okay, I will check what's called the shagreen patches. The shagreen patches present in 50% of the patients. What are the shagreen patches? It's irregular shaped, brown, thickened flakes, okay, usually it's present in the lumbosacral region, okay, it's present in the lumbosacral region. You see how this look like? This is the shagreen patches, okay, brown, irregular shaped, shagreen patches, okay. You may see what's called the ash leaf macules. The ash leaf macules, okay, it's also hypopigmented macules, and it may present on the buttocks or the tracts. So this is called the ash leaves. Okay. The hypopigmented macules or the ash leaf macules, it is diagnostic. It present in 100% of the patient. But the problem is that it's not easy to distinguish that from the for example, it looks always the same. Although it has a specific location, but it looks always the same or almost the same. But it present in all tuberous sclerosis patients, and the green patch present in 50%, so it is not uncommon. The angle fibromas is very important, okay, because it's present in 90% of cases. 90% of cases. Have the angle fibromas, okay. So you see, there are some features that are very common and very specific for the case. Okay, the facial angiofibromas 90%, the adenoma suppression 90%. Okay, in the kidneys, this question was asked. Yeah, I don't know if I said that before. I have a doctor, and I know he's my friend, and he's working as a cardiologist in Al Qasr Al Aini in Egypt. And he told me there's many tuberous sclerosis cases in Egypt. I told him, how do you know that? I didn't see. I see only 2 cases in my life. He told me because all of these patients, once diagnosed, they send them to our unit for checking echo for the cardiac rhabdomyomas. Because the cardiac rhabdomyomas form 70% appear in 70% of these patients. So it's very common for this patient to have cardiovascular problem, shortness of breath, heart failures, murmurs, lower lipidemas, orthopnea. So never miss this part. I will go now through what to examine in the case, but I want you to know that these things are common. You need to know that the cardiac affection of tuberous sclerosis is important, the neurological affection is important, the skin symptoms is important. Okay, the angle fibromas is very important and common. So this percentage is great. And one of the examiners asked how the kidneys are affected by the tuberous sclerosis, and your answer will be what's called the angiomyolipoma. Angiomyolipoma. Okay. Okay, the angiomyolipomas, and some patients may have renal carcinoma, but the percentage is not high. I like this slide very much because this slide gives me personally a great idea about the percentage that I would expect to see in these patients in real life. Okay, so it's very specific. This is very specific and very unique in the criteria and the features that you can find in this case. Okay, I think it's interesting for you as well. Okay, so when you go to examine this patient, no slide for that. I just tell you that you need to check the skin rash for the adenoma separation in the face. You need to check the green patches, which is in the lumbosacral area, brown color. Again, I want you to know the names of the region because when you mention it to the examiner, you don't think that you are creating the feature. So if you said there is ash leaf macules, I'll tell you come here and show me this one. So you need to know what this is called in order to mention it to the examiner. So you will look for the ash leaf macules, which is depigmented or hypopigmented macules over the buttocks. You need to check for café au lait spots. You may find just café au lait spots like the same you see in neurofibromas. The very angle fibromas or the angle fibromas, very important to see if you found it in the nail angles. Okay, you need to offer to examine the eye for fundus examination. Usually he will tell you no need. Okay, but he may ask you what do you expect to find. We need to say I would like to examine the neurological examination. I will offer to examine cranial nerves. Maybe he will allow me or not. Maybe I will offer to do also some neurological examination. The hand, the upper limb. I will examine for the power, for example, the power and the tone and the lower limb as well. And I would like to examine the chest and the CVS, and he may allow you, okay, in order to check. You just make auscultation for pneumothorax and make auscultation for heart failure or any murmur. Okay. Usually the patient have concern about the seizures and about the skin lesions, so you will tell him that this is tuberous sclerosis. It is a familiar condition which run in family due to gene abnormality. This is how to answer this question. It may affect many systems in your body, including the skin and the heart and the lung and the brain and the kidneys as well. So we are going to do some blood tests and imaging in order to diagnose, and there will be a management team with the nerve doctor and the psychiatric and the social doctors to take care and to put your management plan, and we will discuss it with you once ready. Okay, is it treatable? Is it curable, doctor? No, I'm sorry to tell you till now it is not curable, but the scientists are still working on that, and maybe in the future they can find something, but we still need to monitor you closely in order to prevent or control any expected complications. Yes, doctors. So this was for the neurofibromatosis and tuberous sclerosis. Let me just see what you got here. Okay. So now we are done with 3 hours and a half. Do you want to take a break now, or you want to proceed? Please comment on the chat box. Do you want to take a break to eat something, or do you want to continue? What about taking one more case and topic, then we take a break? What do you think? Break. So only Dr. K said continue, Dr. Shah said continue. but most of the others won't. Okay, so let's take one case, then the break. Okay, one more case and then the break. Dr. Imam writing and Virgin. I can't break. Let's take one case, Dr. Imam, then we can move. So now we have Dr. Al-Hadi. Dr. Al-Hadi, are you there? Dr. Al-Hadi Hamid. Okay. Dr. Al-Hadi. Assalamu alaikum.
What's wrong, boss?
How are you?
Oh, nice.
Nice. Okay. It's good to be nice. Okay, so let's see this Zoom today. Let's see your case. The Zoom is horrible today. There's something wrong with it. Okay, so just a second, then you all get your case.
Okay, boss.
Just a second. So can you see my screen now, doctor?
Okay, clear.
Okay, so this is Mrs. Doreen Frederick. She is 43 years old. Thank you for seeing Mrs. Frederick, who has been suffering from painful red raised lesion on her chins for the last 2 weeks, which have been accompanied by malaise. She's otherwise well, although I treated her with a course of amoxicillin 1 month ago for a bout of bronchitis. She smokes 15 cigarettes a day. So the patient with painful red raised lesion with malaise, okay, and she was treated with amoxicillin for bronchitis, and she is a smoker. This is a history case, so you usually have 5 minutes. I'll give you 2.5 minutes to prepare yourself.
Okay.
Okay. Again, doctor, prepare your paper. As I said, write the name and the age. Right? What are the systems that you are going? This is a rash, so you ask about the questions of the rash. Then this history, so you'll not see the rash. So you put the possible symptoms affected here. So you need to ask about the skin. You need to ask about the respiratory system. You need to ask based on what they give you in the case. Then what the system review. Then write the impact and write the summarization. Write the structure. Okay. Don't forget the past history, the surgical, the admission, the travel, the social, and the menstrual. Okay. Then your concern and the management plan. Okay. So just try to write these very fast and see if you can follow in order not to forget any of these. Okay.
Inshallah, okay.
Okay. 2.5 minutes.
Okay, no problem.
So can you start, doctor?
Okay, no problem.
You prepared your paper?
Okay, inshallah, we'll start.
Okay, just a second. Okay, so this is a history case, okay? Start it.
Okay, no problem. Good night. Good night.
Good night, doctor. But good night, you are saying to someone, go and sleep. So good night meaning that you are going to sleep. So good night and close the door and go to your bed. So,
Good afternoon.
good evening, you can say good morning and good afternoon.
Okay, good afternoon.
Good afternoon.
I'm Dr. Hadi, one of the doctors in the General Medical Clinic. Are
Yes,
you
nice to
Mrs. Frederick?
Yes, doctor.
Okay, thank you. Can I confirm your age?
Yes, doctor. I'm 43.
Okay, nice to meet you.
Nice to meet you too, doctor.
Mrs. Frederick, I received a letter from your GP informing me that you are complaining or suffering from a painful red lesion in your shins for the last 2 weeks.
Yes.
Okay, thank you. Mrs. Frederick, I'm going to write some notes, and this work is completely confidential, and my whole attention will be with you.
Okay, doctor.
Okay. Mrs. Frederick, can you tell me more about your complaint?
Yes, doctor. I noticed this rash that present on the front of my legs. Okay, in the last 2 weeks, and this became very painful. In the beginning, I thought that I hit my legs, but actually, it's become in both sides and become painful. It looks like there is some infection or something there. So, can you help me with that, doctor?
Okay, inshallah. Mrs. Frederick, this is a rash started suddenly or gradually?
It is over the 2 weeks, so it starts by one part. Then I noticed that it extends for the two for both sides and increase in size. So I would say it is over the 2 weeks.
Okay. Is it increasing or decreasing or all the time? Same?
It's all the time painful, doctor. I didn't notice something specific increasing it, but it is very painful, especially when I touch it.
Okay. Is there another site other than the chinch?
No, doctor. It's on the chance of my legs.
What is the color of the rash?
It's reddish, doctor. It looks like a red. Yes, it's like a red swelling on my legs.
This is the first time or you have it before?
No, this is the first time, doctor.
Mr. Frederick, is there any something that worsen your condition? Like trauma, stress, exposure to sun?
No, doctor. Only touching these areas in my legs increase the pain.
Okay, thank you. Do you notice anything improve this skin rash?
No, doctor.
Painful? Is it painful?
Yeah, it's very painful.
Okay. Is it blushable?
I don't know what lunch will mean, doctor, but I didn't try. It is painful, by the way.
Any discharge?
No discharge.
No discharge coming out.
No.
Okay, thank you. Mrs. Is there any joint pain?
Yes, doctor. I have severe joint pain.
Is there any fever?
Fever sometimes, doctor.
Is there any loss of gain of weight?
Not really, doctor.
Is there any eye problem?
Eye problem, yes, doctor. I feel some burning and redness in my eyes.
Is there any increase in sawdust or water of work?
Yes, doctor. I noticed that my water work increased recently.
Is there any
My
constipation
urine.
or
What?
is there any constipation? Constipation?
You mean hard stool?
Yeah.
Yes, doctor. I have hard stool, yeah.
How about your mood? Is it low or change?
I'm not sure, doctor.
Is there any chest pain,
Chest pain, no, doctor.
racing of heartbeat,
Not really, doctor.
or leg swelling?
I told you I have some leg swelling. This is swelling in my legs.
Okay, thank you. Is there any you feel fatigue or? Are you
What?
feeling fatigue or-
Yes, I feel fatigue, doctor. Yes, I feel tired for sure.
Is there any sore in your mouth, your throat or something like this?
Sure, no, doctor.
Is there any history of infection of like sore throat or something like this before?
I have chest infection, doctor, last month, for which the doctor gave me antibiotics called amoxicillin.
Is there any tight skin?
Like skin, no, doctor.
Finger color change?
No.
When you're supposed to cold?
No.
Is there any difficulty in swallowing?
Difficulty in swallowing? No, doctor.
Is
No.
there any muscle pain?
Muscle pain? No, doctor.
Is there any menstrual problem, regular or irregular in your period?
No, it's regular, doctor.
Is there any traveling history? You travel abroad or something?
No, doctor.
Is there any medical history, diabetes or hypertension or heart disease?
No, doctor.
Is there any surgical problem like surgical operation or blood transfusion or something?
No, doctor.
Is there a family history of similar condition? Is there a family history of similar condition
No, doctor.
or long-standing disease?
No.
Is there any? Can you show me your drug list, please?
I'm not in anything, doctor. I'm just taking the amoxicillin that the doctor gave me, and I'm done with that. Now I'm just taking some painkillers.
Okay, thank you. Is there any bleeding from any body orifice?
No, doctor.
Okay, thank you. How this affect your job?
Not my job only, doctor. It's affecting all my life. This pain and fatigue. I feel very weak, and I'm not happy with these symptoms for sure. It's affecting my life, doctor, badly.
And daily activity also affected?
Yeah.
With whom you are living?
I'm divorced, doctor. I'm living. Yeah.
Who's supporting you at home?
Only I have my kids.
From the paper given by GP, you are a smoker 50 cigarettes per day. For how long?
Since 20 years, doctor.
Oh. This will affect your life. We will help you by referring you to smoking cessation clinic.
No, doctor. Thank you. I'm good with smoking.
Is there any alcohol? Are you drinking alcohol?
No, doctor.
Okay. Mr. Frederick, as you told me that you complain of this rash for 2 weeks and you are painful on your skins, and there is here you are smoking of 50 cigarettes per day, and this affect your job and affect your life. We are here to help you to overcome this. Mr. Frederick, what is your concern?
Yes, my concern to know what's going on, doctor. I want to know why this condition, why this pain I have in my legs, and I want to know also why, doctor, I have this cough that's continuous, although I take the medicine for the chest infection.
The condition you have called.
2 minutes remaining.
Okay.
Sorry, 3 minutes remaining, not yet. 3 minutes remaining.
You are complaining of disease called sarcoidosis. On the top of my possibility, I will do some investigation to confirm this by doing blood screening, routine blood screening and test X-ray, and I will from the blood also I will check a protein called ACE inhibitor from your blood. And this condition, if it confirmed by sarcoidosis, it is self-limiting. But if it is severe, we will do some medication like steroid. We will give to you. But most of it is self-limiting. We will only observe you and will have a regular follow-up like this, inshallah. And it is will be inshallah will improve by observation only, inshallah. Maybe we need some anti-analgesic, non-steroidal analgesic if there is pain on this, inshallah. Is there any concern, Mr. Frederick?
No, doctor. So it's something serious?
Okay.
Is it something serious?
For the time, I will not tell it is serious or not. but it is can be controllable, and I need some regular follow-up on this. But from the time I cannot say it is serious condition.
Okay, doctor. Thank you.
Okay, thank you.
Okay, time finished.
Okay, thank you.
Okay, doctor. Score for Dr. Al-Hadi. It is the score time. Let's see the scores, Dr. Al-Hadi. He gave you between 14 to, most of them between 14 to 17. Okay.
Okay, good.
Okay, doctor. So let me ask you, what?
Okay. First
What?
time.
Yeah,
This is
first time.
to practice.
Yeah, if it's first time, this is great. Okay. This is great the first time. There's some points I would point to. I like your, I would say the positive points first. I like that you utilize your time. You didn't waste any time without asking some questions. So this is very good. Okay. And the other thing, your system review, system review, you go point it to what you are looking for, then you ask it and confirm it all what you want. So this was a good approach for this case. Okay. So for, as you said, just there's some comments on the experience of practicing the paces. You used a lot of jargons. Okay.
Yeah. So,
and you said something called ACE inhibitor. It is not called ACE inhibitor, it's called ACE. The other thing, you're using a lot of Arabic words. You're saying yani, you're saying inshallah. Okay. So this can't be in the paces exam. Okay.
Yes.
You can say inshallah we're going to do something because they don't know what's inshallah, so they will consider it something that nobody understands. Okay. So this is about some issues in the performance, medically in the performance in the medicine. Okay. What do you think the name of the skin lesion?
Erythema nodosum, I think.
Okay. What's your differential for erythema nodosum?
First differential is sarcoidosis.
Okay.
Streptococcal infection.
Streptococcal infection. Okay.
TB.
So why you didn't ask anything about this mode of infection? Did you ask the patient if she had cough?
Yeah. I forget to ask about the chest cough and cough of blood.
No, she had chest infection, and you're thinking about sarcoidosis. So where's the cough?
Yeah.
Okay.
Okay.
So what else other than streptococcal and sarcoidosis? What else?
I think TB also.
Okay.
Some medication.
Tell me about this medication. Do you know anything of it?
Sulfa, penicillin.
Okay. So amoxicillin can cause something like that?
Yes, one of the penicillin.
What about the oral contraceptive pills? Is it an important question in this case or not?
Yeah. Yes.
Important, right?
Yeah.
Okay. I like when you ask about bleeding from any orifice. Why are you asking this question?
This is one of the routine.
Can we stop yani? Dr. Hadi, you need to stop the word yani.
Yes,
I know. We are all used to use our Arabic language and these connectors. But can you make it well? Just say well. Well, I'm asking that because of that. Okay.
Yeah.
So try to practice that before the exam. While talking to the people, try to use well instead of yani. Okay.
Or your point.
No, because it's a big problem. It's a big problem to put Arabic words in your exam because they consider it something disqualifying. I think, you know.
Sounds.
Great. So you asked, but inflammatory bowel disease is a cause of erythema nodosum as well, right?
Yeah.
So inflammatory bowel disease, Crohn's and ulcerative colitis can be a cause of erythema nodosum. So it's important. I like when you ask the question, even if you didn't mean it, but that's it. Okay. So your differential was not bad, but you need to ask the oral contraceptive pills. You need to dig more deeper into infection. And the lesson here, Dr. Hadi, also remember they put anything in the scenario for a reason. So they put this infection, the course of amoxicillin, the chest infection for a reason. You need to ask about the cough, and the patient will tell you that the cough is not new. The cough is since 6 months. So the cough here could be related to smoking, could be related to sarcoidosis, could be related to the infection, right? But because it's before the infection, okay, it is related to the sarcoidosis and smoking. You agree with me?
Okay. Thank you.
Right?
Okay.
So thank you very much, doctor, for the first time practicing. This is more than great. Thank you.
Okay. Thank you.
Okay, doctor. Thank you. So now let's go through. I'll close your mic, Dr. Hadi. Okay, we will go through the erythema nodosum. Yes, I agree with Dr. Hadi. Okay, this is a case of erythema nodosum. Okay, you can see how it looks like. Looks like a bulbs or painful red bulbs on the chin, and it's really very painful. Okay, then this page I want you to write because you will not have this written in your slide, I think. So you will only find the word sputile. So remember, the erythema nodosum is tender, red, smooth, shiny nodules. So tender, red, smooth, shiny nodules. Okay, the S refers to sarcoidosis. The other is for streptococcal infection. So the patient with recent chest infection, this itself can be the cause of the rash. Then streptomycin as a American medicine, sulfonamide. There is some group of other medicine, but it's not important. If you found in a patient list medication that you don't know, you can ask. I'm not sure if this medicine causing erythema nodosum or not. Then the P for pregnancy. So you need to ask about the menstruation. You need to ask about regular menstruation. If it's not, so you ask this question. So if menstruation is absent since 2 or 3 months, so it could be pregnancy. The oral contraceptive pills, you need to ask specifically about the OCP. Then the TB, you need to ask about night sweating, weight loss, coughing out of blood, exposure to a patient with a cough or a sick patient. Inflammatory bowel disease. So ask about bleeding coming with the back passage, tummy pain. Lymphomas. Ask about again night sweating, lumps and bumps anywhere in the body, weight loss, loss of appetite. So these are the common. There's a lot of causes for erythema nodosum, but this is the most common that you may face in your PACES exam. When the case of erythema nodosum appear in station 5, you will not only do as usual, because again, this is the lesson that we learned today. You are not going in a skin cases to look to the skin and say, hey, I'm done. Because again, erythema nodosum is not a difficult thing to diagnose when you see it. It's a little bit unique. The only things you need to put some differential, insect bite. You need to put something like erysipelas and cellulitis as a differential for the erythema nodosum when you see it. But the point, how would I proceed? Let me say that I check that, and this is erythema nodosum. What should I examine to get the full mark of examination? And if you are in Ireland or going to the new system of the PACES, you'll have time and you need to do a super full examination. So here I will say the skin first. I will check the skin. It will be tender, red, smooth, shiny on the chin. Then the chin, I will go to examine the neck. Now I'm done. It is erythema nodosum. I will think about the differential. So I will think about something like lymphoma. So I will offer to examine the lymph node in the neck. And okay, a sarcoidosis infiltration. Sarcoidosis can infiltrate anything, and sarcoidosis itself causes lymphadenopathy. Okay. Then I will offer to examine the joint. So if the patient said I have any hand pain, any elbow pain, tell him, can I see, just feel the limb, check the tenderness, check if any deformity, check any swelling. Then I should examine the chest in this patient. It will be a big problem if I didn't examine the chest. Okay. And then maybe lung fibrosis. Sarcoidosis can cause lung fibrosis. There could be signs of TB as well, which will cause also fibrosis. Then I will offer to examine the abdomen. Sarcoidosis causes infiltration of the abdominal organs, so it can cause organomegaly, splenomegaly, hepatomegaly. There could be in the abdomen scar of inflammatory bowel disease as well. Any previous surgeries. So you will not only look to the skin, you will offer to examine all these things. Again, you started from the hands and go to the neck, the joints, the hands, the chest, and the abdomen, and that's it. Okay, this is for the erythema nodosum. Then I will show you specifically for sarcoidosis. Sarcoidosis is a very important topic. It can come in station 5, and there is also 2 or 3 cases. There is one patient, female patient in Egypt. She has sarcoidosis. They brought here many times because of Cushing, because she's in high dose of steroid, because of the lung fibrosis, so it can come in station 1. Because of, as I told you, Cushing, because of diabetes, okay, diabetic eye, because she's on steroids and she's diabetic. So the patient can come in different ways. Again, as usual, what to examine in the case of sarcoidosis, instead of looking to different books, you will use only the slide that we made. The first thing, ask about the lung. So ask about the cough. Very important question. Cough that doesn't go away. Chest pain, shortness of breath. Okay. Lymph nodes. There could be swelling in the neck, under the chin, the armpit, and other areas. You need to offer to examine the lymph nodes. The heart. Sometimes there will be irregular heartbeat, swelling in the legs for heart failure. Skin. Painful red bumps on the arm and legs for erythema nodosum. Discoloration of the nose and the chin for lupus pernio. Small brownish skin patches sometimes. The joints and pain because there is joint pain and tenderness sometimes. Okay. Then the eyes. There could be blurring of vision. Okay. Eye eye pain and dryness. Then here, remember, this is not enough. Ask for hypercalcemia signs and symptoms. So ask about polyuria and polydipsia and tummy pain and mood and hard stool, constipation. Then also, because this patient usually, if the patient is known as sarcoidosis for any reason, never forget to ask about the complication of steroids, which is high blood sugar, high blood pressure, easy bruises, stretch marks, okay, bone pain, fractures. So remember, if the patient is non-steroid and they brought him for any reason, remember to ask about the steroid side effects. What to examine for patient of sarcoidosis? If you catch it sarcoidosis, I will look to the face to check for lupus pernio, red eyes, and parotid enlargement. I will offer to examine the neck and the armpits, okay, and the submandibular area for the lymph node enlargement. I will auscultate the chest for lung fibrosis and make percussion. As you know, in station 5, you don't need to do full examination. You will just put, the stethoscope and make some percussion to check for fibrosis. The abdomen, I will cause palpation for hepatosplenomegaly. The skin, I will look for erythema nodosum and signs of steroid usage, like thinning of the skin and easy bruises, and for the joints pain. I need to order chest X-ray, ESR, and ACE, not ACE inhibitor. It's called ACE level. Throat swab for streptococcal infection and TB serology. Okay, so this is what is called sarcoidosis. Okay. Last thing before we go to break, just this case because it appears also recently. Okay, and there is also 2 cases. If you went to Dr. Ramadan clinical course, he's bringing 2 cases of ichthyosis, and it appears in the exam. The examiners like it very much. You see how it looks like the cantaloupe, or it looks like very dry skin. Okay, the causes of ichthyosis. Actually, when it came in the exam, it is related to malignancy or related to HIV. So they will put a history of malignancy or a history of HIV. When you see a case of ichthyosis, there will be a malignancy or HIV. So I want you here to add infections. So the causes of ichthyosis is inherited. There is what's called ichthyosis vulgaris. Write it because you will not receive this. This slide will be empty. Only the picture. So write inherited. Okay, inherited. So there's what's called epidermolytic hyperkeratosis and ichthyosis vulgaris. So sometimes it's running in the family. So ask if there's a family history. It's called ichthyosis vulgaris. Ichthyosis vulgaris. Forget about the first one. It's called epidermolytic hyperkeratosis. Then write metabolic, like Rafson disease. Then malignancy, lymphoma, multiple myeloma, breast cancer. Okay. Add to this esophageal cancer also. So breast cancer, esophageal cancer, lymphoma, multiple myeloma. So if the patient came and there is some ichthyosis and it is not since birth, you need to ask bundle 1 for the lymphoma and for other cancers, back pain, signs of hypercalcemia. You need to ask if there's a family history for that, for the inherited and metabolic, and you need to ask the risk for HIV, like tattooing, unprotected casual relation, not recent, a little bit old. There's also an infection that can cause it, which causes the HTLV, which is the human T lymphocytic virus. It's also causing the ichthyosis. Okay, I hope you wrote that. So inherited, as I said, ichthyosis vulgaris and epidermolytic hyperkeratosis, malignancy, lymphoma, multiple myeloma, breast cancer, esophageal cancer, infection, HIV, and HTLV, metabolic Rafson disease. The important advices for this patient: regular emulsion, using regular emulsion, and not to be exposed to the sun because there is, there is no sweating. So any sun can cause burn. With this skin, it's very dry and there's no sweating, so nothing to protect the skin from the sun heat. So there could be up to second degree burn with prolonged exposure to the sun. This is called ichthyosis. Okay, ichthyosis. So now it's the break. Alhamdulillah, there is nothing. The remaining part is not tough. Inshallah, it will be simple. So now the break. Voting for the break. Tell me first, what do you think about the skin now? Do you feel some improvement in the skin, in the dermatology, and its relation to PACEs? For sure, I'm not teaching the general dermatology. I'm teaching the dermatology that's related to PACEs. So do you feel a little bit more confident with the common cases that may be seen in the exam? Yes, Dr. Jim, if you missed some, you can take the lecture. Dr. Wafi is satisfied by 100%. And Dr. Ibrahim said yes, better. And Dr. Naman said much improved. Dr. Hadi said very good. Dr. Shazia, yes. Okay. Okay, good. Dr. Imam said I was hating dermatology, but now I'm enjoying it. Thank you very much, Dr. Imam. Thank you. Because now we're using an applied dermatology. It's applied, so we know how to use it and how to approach it. I will tell you, the problem with the dermatology actually is usually how would I proceed? Because the dermatologist is for diagnosis. So what I'm going to do in the station, why I lose marks. So now if you know your approach, so inshallah, there will not be any problem. Okay, so now let's go to a break. Then we can come back to the simple remaining part. What do you recommend? 15 or 20 minutes? 15 is okay. Let's make it 15. Let's make it 15 in order to allow you to. Dr. Jim, you need 200 minutes? Dr. Jim, 200 minutes. So 20. Okay. So now it's 10:17. Come back. Okay, 10:35. Come back 10:35. Okay. So I make it 18.